Okay, so this is the first lecture for you in this GIS uh, course, which is the anatomy of the anterolateral abdominal wall or anti-abdominal. Usually we call it as anti-abdominal wall, as well as the peritoneum. Okay. Uh, so if you see the abdomen, usually it has divisions. Okay, so the whole of the anti-abdominal wall is divided into 9 quadrants, or it is also called as 9 regions. Okay, so 9 quadrants or 9 regions. How do you divide this abdomen? Because abdominal pains are very vague, and if there are any injuries to the abdomen or any pains referred to the abdominal wall, you should be it will be very vague. So you should be able to relate it to the 9 quadrants. And if you want to locate any of the abdominal structure, so you should be able to tell in which region it is present, okay, or which quadrant is present. So for this, for the simplification of the abdomen, so we divide it into 9 regions or 9 quadrants by 2 transverse lines. So this is the first line here. So this is called as the transpyloric plane, because it passes through the pylorus of the stomach. This is the pylorus of the stomach here. So it passes through the pylorus of the stomach. So that is called as the transpyloric plane. Then we have the second line, okay, transverse line, which is also called as the intertubercular plane, because it passes through the 2 tubercles. And here are the tubercles of the hip bone. Okay, so it passes through the tubercle. Okay, so it is called an intertubercular plane. This is called as the intertubercular plane. Okay, so there are 2 transverse lines or horizontal lines. One is the transpyloric and in the upper part of the abdomen, and the second is the intertubercular plane below. Okay, so these are 2 transverse planes. Now there are 2 vertical lines. So these are the 2 vertical lines. Okay, so these are called as the right and left lateral vertical planes. Right and left lateral vertical plane. Sometimes they are also called as the mid-inguinal plane or the mid-inguinal plane of a mid-inguinal line. So it is also called as the mid-clavicular line, because it passes from the clavicle up to the mid-inguinal point. So these are the 2 vertical planes on either side. So there are 2 horizontal planes or transverse planes, which are called as the transpyloric and the intertubercular plane, and then 2 vertical planes. These are called as the right and left lateral vertical planes, mid-inguinal planes, or the mid-clavicular planes. Anything. Okay. So now this is divided into 9 quadrants: 1, 2, 3, 4, 5, 6, 7, 8, 9. So here are the 9 planes. Okay. So these 9 regions or 9 quadrants. Okay, which are those? What are they? So if you see from above downwards, which are the three which are present in the midline, in the middle part. So from above downwards, the first one will be called as the epigastrium. Epigastrium, because it is above the stomach. Gastrium means stomach, above the stomach. So this is called as the epigastrium. Okay. Then we have the second region just below the epigastrium. This is called as the umbilical region or the umbilical quadrant. Then below we have one more, the below. Okay, so this is called as the hypogastrium. So this is the epigastrium. Epi means above, and this is below. Hypo means below. So it is below the stomach, so it is called as the hypogastrium. Epigastrium and hypogastrium, and in between we have the umbilical region. So these are the 3 regions or quadrants in the middle part of the abdomen. Now on 3 on the right and left side, okay, on the lateral side, from above downwards, these are the 2 regions, right or left. So this is called as the right and left hypochondrium. Hypochondrium. Chondria means cartilages. So it is below the chondrium. So the cartilages. So it is called as hypochondrium. Either so here is the cartilage. So it is just below the cartilage. So these are called as the right and left hypochondrium. The next will be here. So these are called as the right and left lumbar regions. Right and left lumbar regions. Okay. Then below we have one more. This is called as the right and left iliac region. So these are the 9 quadrants. So once again, so this is the epigastrium. This is the umbilical. This is the hypogastrium. Here this is the the hypochondrium, right or left. Then we have the lumbar, right or left. Then we have the iliac region. So now, whenever we talk about the abdomen, we always correlate with the which region we can trace. If you become a surgeon and if you want to operate on a particular organ, so you should be able to locate where exactly you are supposed to put the incision. So you should know which are the regions and which organ or the structure is present in which region of the abdomen. Okay, so these are the 9 quadrants of 9 regions of the abdomen. So now we should be able to relate any of the organs here or any pain which is referred here into this regions. We should be able to relate where is the pain, which is in the epigastrium, hypogastrium, umbilical, or like other hypochondrium or the lumbar or the iliac regions. Okay, now coming to the anti-abdominal wall as our topic. Um, uh, so if you want to trace what are the structures which are present in the anti-abdominal wall, what are the layers of the anterior abdominal wall? Okay, so the first most superficial, as you know, is the skin. Whenever we touch our the abdomen, it will be the skin. So this is the skin here. Then just deep to that, so this is the side view of the whole of the structure, anti-abdominal wall. So we are seeing from the side. Okay, so this is the skin, and just deep to that, this is the superficial fascia. Superficial fascia has two parts. One is the superficial fatty layer, so which is the fatty layer here. This is also called as the campus fascia. Campus fascia. Then deep to that, there is the deep membranous layer. So this is the deep membranous layer. This is the fatty layer, superficial fatty layer, and deep to that is the deep membranous layer, which is also called as the scarpa's fascia. Scarpa's fascia. Okay. So this is the two parts of the superficial fascia itself. Okay, superficial fatty layer. Then we have the deep membranous layer. Both are layers of the superficial fascia. So there is no deep fascia here in the abdomen. There is no deep fascia. Okay. Then deep to that we have the muscular layer. There is a thick muscular layer. These are the muscles which are present within the abdomen. Okay. Okay. So the muscular layer has 3 layers: the external oblique, the internal oblique, as well as the transverse abdominal. Just a minute. Okay. So the external oblique, then we have the deep to that we have the internal oblique, and then we have the transverse abdomen. These are 3 layers which is forming the together. It is called as the muscular layer. So there are 3 layers of the abdomen. Okay. So, but there are more than 3 muscles actually. We'll discuss it in detail later. So, just we know this is the muscular layer, this is the superficial fascia, then deep to that we have the muscular layer, okay, which has 3 muscles which you can see here. Okay, external oblique, internal oblique, as well as the transverse abdominis. Then deep to that we have the deep to that we can see here. This is called as the fascia transversalis, although it is also called as the transversalis fascia. Okay, fascia transversalis or the fascia transversalis or the transversalis fascia. Okay, then deep to that we have the peritoneal layer. This is the parietal peritoneum. Then we have the visceral peritoneum, which is attached to the abdominal organs. So these are the different layers which form the anterior abdominal wall, or these are the layers of the anterior abdominal wall. Anti-abdominal wall, also called as the anterolateral wall. Okay, so skin, then we have the superficial fascia, which has 2 parts: fatty layer as well as the scarpa's fascia, membranous layer. Then we have the muscular layer, which has 3 parts: external oblique, internal oblique, and transverse abdominis. And then deep to that we have the fascia transversalis as well as the peritoneal layer. Okay. Then within the peritoneum, as I said, we have the parietal peritoneum. Okay. Now going to if we see the muscular, once you remove the skin and superficial fascia, the most important structure will be the abdominal muscles, which form a thick layer which will give the strength to the abdominal wall. Okay, so these are the muscles. Okay, we will talk about them in detail one by one. Okay, so this is the external oblique muscle. So this is the external oblique, this is the internal oblique, then we have the transverse abdominis. So this is the transverse abdominis. Okay, see the direction of the muscles. Okay, muscle fibers. So external oblique begins from above and ends below. The internal oblique will be reverse. Okay, start from below and ends at the above or the origin and insertion. Then transversalis, as the name indicate, transverse. So the fibers will be running transversely. We'll go one by one. The first muscle we'll come across after the skin and the superficial fascia will be the external oblique muscle. This is the external oblique muscle here. Okay, so the origin, whenever we talk about the muscles, we always talk about the origin, insertion, and the direction of the fibers. Okay, so as we can see here, the origin of the muscle is from the outer surface of the lower 8 ribs. So there are 12 pairs of ribs, as you know. So the lower 8 means starting from the 5th, 6th, 7th, 8th, 9th, 10th, 11th, and 12th. So all these are the lower 8 ribs which will give origin to this muscle. Okay, then the fibers start from here and they run downwards, forwards, and medially towards the center. Okay, this is the direction of the fibers. So the arrows are indicating the direction of fibers. Then we have the insertion. So insertion, where is it inserted? So it will be inserted so to the xiphoid process. Here will be the xiphoid process, which is an extension of the sternum. Okay, the lowermost part of the sternum is called as the xiphoid process here. Then we have a line in the center. This is called as the linea alba. Linea alba, central line. Alba, linea means line. Alba means because it is a white line. It looks like a white line running all the way from the abdomen, from the xiphoid process up to the pubic symphysis. Okay, pubic symphysis. So this is the line running from all the way from above downwards. Okay, pubic symphysis from the xiphoid process up to the pubic symphysis. So this is the linea alba. Then going below there is pubic crest and pubic tubercle will be here. So pubic crest and this pubic tubercle. Then we have the anterior superior iliac spine. ASIS means anterior superior iliac spine. Here is in the most anterior part of the hip bone. This is called an anterior superior iliac spine. Okay, as well as the anterior half of the outer lip of the iliac crest. Iliac crest. This is the iliac crest. The outer lip of the iliac crest. All these are the insertions starting from the xiphoid process, linea alba. Then we have the pubic symphysis, pubic crest, and pubic tubercle. Then we have the anterior superior iliac spine as well as the outer lip of the iliac. This is the insertion of this muscle. So origin is from the lower 8 ribs and the insertion will be all this. Okay, so this is the origin and insertion of the external oblique muscle. And here in the lowermost part, these fibers, same fibers are also forming the inguinal ligament. We'll talk about this, the lower free margin of the external oblique muscle. Here, if you see here, so this is the free fibers of the external oblique, which will form the inguinal ligament. Inguinal ligament. Okay, so this is the inguinal ligament here. Okay, so this is the inguinal ligament. Okay. So here also you can see this is the inguinal ligament. Very important structure. We'll talk about this in some detail later. Okay. So these are the fibers. This is the external oblique muscle, and the lower. This is the anterior superior spine, and here is the pubic tubercle. And in between we have this free part of the external oblique, which is called as which form the inguinal ligament. Okay. Okay. Now coming to some openings here, very important opening here. This is called as the superficial inguinal ring. So in the lowermost part of the external oblique, we saw this is the inguinal ligament, and in the most anterior part here, you can see an opening. This is called as the superficial inguinal ring. It's an oval slit in the lower aponeurotic fibers of the external oblique. So it is in the external oblique muscle, the aponeurosis. Aponeurosis means thin facial part of the muscle, which is called as the aponeurosis. So in the lower aponeurotic part of the this extra oblique, you can see an opening, okay, or oval slit, okay. So this is called as the superficial inguinal ring, just above and lateral to the pubic tubercle. Here, as I said, this is the pubic tubercle, this is the pubic crest here. So just above the pubic tubercle, you can see an opening. This is called as the superficial inguinal ring, okay. So this is a very important ring, especially in case of the inguinal hernia. If you understand this concept, then you can understand the inguinal hernias better. Okay. The lateral crus attaches to the pubic tubercle. As you can see here, this fibers will form a crus. This is called a lateral crus, and here is the medial crus. So the lateral crus is attached to the pubic tubercle. It is attached to the pubic tubercle, and the medial crus attached to the pubic crust. So you can see here, in between is the opening. Okay. Its base is formed by the lateral part of the pubic crust, and if you see here, so the base is formed by the pubic crust. So this is the opening, open slit, oval slit. This is called as the superficial inguinal ring. So this is the opening through which all the abdominal contents, if they protrude out, they will protrude out through this. Okay, and they form the inguinal hernia. Now coming to the next muscle deep to the extra oblique. If you remove the extra oblique, then you can see the internal oblique. This is the internal oblique muscle. So the origin of this is just opposite to that of the extra oblique. That is, it starts from the inguinal ligament, okay, as well as the anterior two-thirds of the iliac crest. So the extra oblique was inserting into this part. Now this the intra-oblique is taking origin from here. Okay, so the origin of this intra-oblique is from the lateral two-thirds of the inguinal ligament, this inguinal ligament, as well as the anterior two-thirds of the iliac crest, as well as the lumbar fascia. So the origin of this muscle is here. So the origin of the extra oblique was from here, and the insertion was here on this. But the origin of this muscle, intra oblique, which is deep inside the extra oblique, is here. Okay. So at the lateral two-thirds of the inguinal ligament, then the anterior two-thirds of the iliac crest, as well as the lumbar fascia. Okay. Then the direction of the fibers. Okay, the direction of the fibers is upwards, forwards, and medially. So it is running upwards, forwards, and medially at right angles with the fibers of the extra oblique muscle. Okay, so it is running upwards. Okay, towards the center. Okay, the extra oblique was taking origin from here and going downwards, but the intra oblique will be in the opposite direction. Okay, then the insertion will be into the lower three ribs. Lower three ribs. So insertion of this muscle will be into the ribs. The origin of the extra oblique was from the ribs, but the insertion of this intra oblique is to the lower three ribs and their costal cartilage, ribs as well as the costal cartilages. Then we have the xiphoid process, linea alba, pubic crest, and pubic tubercle. So the origin of the muscle is from here. Then the insertion will be into the lower three ribs, pubic, the xiphoid process, linea alba, all the way, pubic crest, as well as the pectineal line here. There will be pectineal line over the hip bone. So all this will be the insertion of this interoblique muscle. Okay, so this is the origin here, and the direction of fibers going and getting inserted here. Okay. Then the third muscle is called as the transverse abdominis. Transverse abdominis. So the origin of this muscle will be from the lateral one-third of the inguinal ligament from here. Okay. Then the anterior two-thirds of the inner lip of the iliac crest. So the anterior two-thirds of the iliac crest. So then the lumbar fascia, similar to that of the slightly similar, but not exactly, so slightly similar to that of the intra-oblique. Okay, so this is the lumbar fascia. Then the lower six costal cartilage, so lower six ribs as well as the costal cartilage. That is starting from the 7th, 8th, 9th, 10th, and 11th, 12th. Okay, so this is the origin of this muscle, transverse abdominis. Direction of fibers will be, as the name indicates, it will be running horizontally because it is mentioned transverse. Okay, and the insertion will be similar. Xiphoid process, linea alba, pubic crest, and pectineal. All the three muscles will be inserting to this Default process, linea alba, pubic crest, and the pectineal lines. Okay. So if you have any doubts still here, you can ask me.
All clear, doctor.
Okay. Just a minute. Okay. So this is the origin, and that was the direction of fibrous and insertion. Okay. Now coming to the inguinal canal. Okay. Uh, Coming to the inguinal canal, so here is the inguinal canal, a very important structure, as we know, which is part of the inguinal hernias. So we should know what is this inguinal canal. So it is an oblique intramuscular passage in the lower medial part of the anti-abdominal wall. So in the medial part, lower medial part. Okay, so this is the canal here. So in the anterior abdominal wall. Okay, so this small oblique intramuscular passage, okay, in the lower medial part of the anti-abdominal wall, this is called as the inguinal canal. So you can see it is the inguinal canal. Here you can see the inguinal canal. What we saw here, this is the superficial inguinal ring. So this was the superficial inguinal ring which we saw. So it runs just above and parallel to the medial half of the inguinal ligament. So this is the inguinal ligament here. So it runs just above and parallel to the medial half of the inguinal ligament. Its length is about 2 inches. So this is the total length of this inguinal canal, almost 2 inches or 5 centimeters. It is 2 inches of 5 centimeters long in case of an adult. Okay, so this is the total length of this, which will be 2 inches or 5 centimeters long. It gives passage for the spermatic cord. Very important structures are there. One is the spermatic cord in case of male, and in case of female, it will be the round ligament of the uterus. Okay, so these are the two contents, along with some nerves as well as some of the lymph nodes they are present. Okay, so these are some of the only contents of this canal. In case of male, it will be the spermatic cord, and in case of female, round ligament of the uterus, along with some nerves like the ilioinguinal nerve, which is present in both male and the female. Okay, as well as some of the group of lymph nodes like the superficial and deep inguinal, the lymph nodes, as well as some of the lymphatic cilia passing through. It connects between the superficial and deep inguinal ring. So if you see, this canal is a very important canal which connects the superficial. We already saw the superficial, and here will be the deep inguinal ring, which will give passage for it will open into the inside the abdomen and gives passage for the abdominal contents to run to enter into the deep inguinal ring, pass through this canal, and come through the superficial inguinal ring. Okay, if there is weakness in the abdominal wall, normally it doesn't give passage to any structure except this spermatic cord in male and the round ligament of uterus in female, along with the ilioinguinal nerve as well as some of the lymphatics and lymph nodes. Now coming to we have studied already the external oblique, internal oblique, and transverse abdominis, three muscles. Now we are going for the fourth muscle. This is called as the rectus abdominis muscle, a very important muscle in the front. So this is called as the rectus abdominis muscle on either side. This is the rectus abdominis. Okay, with two heads from the symphysis pubis. So symphysis pubis is here. So this muscle will take origin from this, not from above. Usually the muscles will take origin from above and get inserted below. But here it is reverse. It takes origin from the pubic symphysis. Here is the pubic symphysis. So it will take origin from here by two heads from the pubic symphysis, the symphysis pubis as well as the pubic crest. Okay, and then runs all the way above and get inserted to the fifth, sixth, and seventh costal cartilage as well as this fourth process. So the fourth process is in the center here, and the fifth, sixth, and seventh costal cartilages. Fifth, sixth, and seventh costal cartilages. It's separated from its fellow by the linea alba. If you see here, all these muscles are in pairs. Okay, external oblique, internal, transverse abdominis, and even the rectus abdominis. One on the right side, one on the left side. So they are always in the pairs. So the right and the left are separated by the central line. Now here you can see here, this is the linea alba, white line running from all the way from the xiphoid process to the pubic symphysis, where all the muscles are getting inserted. So this is the linea alba. Okay, it is separated from its fellow by the linea alba. So the right and left rectus abdominis are separated from the linea alba. Its lateral border is called the linea semilunaris. On the lateral side of this rectus abdominis, we have one more line. This is called as the linea semilunaris on the lateral side. In the center, we have the linea alba. On the lateral side of this rectus abdominis, we have the linea semilunaris. And extracted from the tip of the nine costal cartilage from here to the pubic tubercle. Runs all the way, it goes up to the pubic tubercle. This is called as the linea semilunaris, and this is the linea alba. There are two important lines here. It is divided into distinct segments by three transverse tendinous intersections. If you see, this muscle is divided into four parts by three transverse lines, three transverse intersections. Okay, three transverse tendinous intersections. Okay, so here you can see one is passing through the umbilicus, and one is near the xiphoid process, and the third one will be in between, which will divide this muscle into four parts. Okay, so this will give the six packs for the abdomen. Okay, this will actually, the rectus abdominis will show the six packs in a bodybuilder. Okay, so it is divided into distinct segments by three transverse tendinous intersections. So these are three, 1, 2, and 3. Here also you can see 1, 2, and 3 transverse intersections. One at the level of the xiphoid process, as I said, one is at the xiphoid process, the second at the umbilicus, the second at the umbilicus, and one in between the two. In between, the midway between the two will be the third. It is enclosed. This whole of this muscle is enclosed in a sheath called as rectus sheath. If you see here, here is the rectus sheath, and here the rectus sheath has been removed. Okay, so it is always covered in the front and in the back, superficially as well as deep, by the rectus sheath. We'll talk about that later. Okay, the rectus sheath, very important structure. Then we have the fifth muscle called as the pyramidalis. If you see, a very small muscle which is present near the pubic crest and the pubic symphysis. So there is a triangular muscle. That's why it is called as pyramid. It looks like a pyramid. So that's why it is called as pyramidalis muscle. Very small muscle. Okay, it arises by its base from the front of the pubis and inserted into the linea alba. So it takes origin from the pubic symphysis here, pubis, as well as getting inserted to the linea alba. As you see here, all these muscles have a very important role in the formation of the linea alba. Okay, so this also get inserted to the linea alba. Now coming to the rectus sheath. Okay, I said the rectus abdominis is covered by a sheath called as the rectus sheath. Okay, so the rectus muscle is covered in the front superficially as well as deep by the rectus sheath. So if you cut a section, we can see the both the layers. If you take a section at this level and here, you can three at different positions. Then we can see this is the rectus abdominis muscle. Okay, and here is the sheath. So if you see here, this is the sheath on the front. So here this is the superficial and the deep layer. If you take a section at these levels and see from the side, okay, so then you can see the rectus abdominis muscle here, and you can see here the rectus sheath covering the front and the back, or two superficial and deep. So I said we will take the section at three levels. Okay, and the top here, and in the middle and below. Okay, so these are the three. Okay, one above the costal margins. Okay, the rectus sheath is formed of the aponeurosis of the lateral three abdominal muscle. I said aponeurosis is nothing but the flattening of the muscle. Usually, whenever the muscle is inserted to a bone, then it is called as tendon, the tendon. So it is called as tendon whenever the muscle is inserted to the bone. When it is not inserted to the bone, but it becomes flat and thin like a sheath, then it is called as aponeurosis. So here also you can see here the external oblique, internal oblique, and transverse, all the three muscles from superficial to deep. So when they come here, they become thin like a sheath. This is called as the aponeurosis. They are not strong and attached to the bone. They are not attached here any to any bone. Okay, so they are not called as tendons, but they are called as aponeurosis. So the rectus sheath, this rectus sheath is formed of the aponeurosis of all the three muscles, the lateral three abdominal muscles, external oblique, internal oblique, and transverse abdominis. You see here, all these three will contribute in the formation of the rectus sheath. It contains rectus abdominis muscle as well as the pyramid amellis muscle. We already saw inside this rectus sheath we have the rectus abdominis, and below we have the small muscle called as the pyramid amellis. Okay, it contains rectus abdominis, pyramidalis. Along with that, there are some important nerves, the anterior rami of the lower six thoracic nerves. If you see here, the thoracic nerves, they are coming at each level. So the lower six thoracic nerves, the superior and inferior epigastric vessels. If you see here, this is the inferior epigastric vessels, artery and the vein. Similarly, there will be vein and artery coming from above. Okay, that will be also present within this sheath. So from below there will be inferior epigastric, from above there will be superior epigastric vessels, both artery and the veins, as well as even there will be lymphatics. All are the contents within this rectus sheath. Okay, it is considered three different levels. As I said, we'll take a section at three different levels, and we try to see this rectus sheath covering the rectum because it is different at three different levels. Above the costal margin, first one is at the above the costal margin here, somewhere here. If you take a section, what will happen? So above the costal margin, the anterior wall is formed of the external oblique muscle aponeurosis. The posterior wall is formed of the 5, 6, and 7 costal cartilaginous and intercostal spaces. So if you see anteriorly, we have the external oblique, EAO means external oblique muscle. So running all the way in front of the rectus abdominis muscle, and below, if you see deep inside, we can see the 5th, 6th, and 7th costal cartilages as well as the intercostal space. Okay, so this will be the posterior wall. This is the anterior wall, and this will be the posterior wall. Okay, then if you take a section at the lower level between the costal margin and the level of the anterior spine, if you take a section here between the costal margin and the anterior spine in the middle here, so how it looks like here, if you take, this is how exactly it looks like. Okay, between the costal margin and the level of the anterior spine, if you take a section, the aponeurosis of the internal oblique splits into two lamina. If you see here, there are three muscles: external oblique, internal oblique, and transverse oblique. The internal oblique will come near the side of lateral part of the rectus sheath, rectus abdominis, and it divides into two layers. The aponeurosis of the internal oblique will divide into two layers. One layer will go in the front anteriorly, one will go posterior to the this rectus abdominis muscle. Okay, so the aponeurosis of the internal oblique splits into two laminae, the external and the internal. The external lamina fuses with the external aponeurosis. If you see external oblique aponeurosis, it splits, it joins with the external laminae will join with the external oblique. The internal laminae will join with the transverse abdomen. The external lamina fuses with the external oblique aponeurosis. The internal laminae will fuse with the transverse abdominis muscle. So it will go here. So all the sides, it is totally covered by the rectus sheath. So this is the rectus abdominis covered by the rectus sheath. Okay. Below, if you take a section at a lower point, okay, so here, if you take a section at this level, okay, the posterior wall is deficient of the aponeal. If you see here, this is the posterior wall or the posterior sheath of the external lip. So below it is deficient. So there is no rectus sheath below in this part. So if you see here, there will be no sheath here. Okay, not like here. If you take section at this layer, so you can see both anteriorly and posterior is covered by the rectus sheath. But if you take a section at the lower part, because the posterior sheath ends here, so here it is deficient. Okay, so there is no posterior wall in the lower part. Okay, below the level of the anterior superior iliac spine and the pubis, the aponeurosa of all the three muscles form the anterior wall. If you see here, all the external oblique, internal oblique, and transverse abdominis all will go in the front. So they form the anterior wall only, and it is deficient in the posterior wall. So the aponeurosa of all the three muscles form the anterior wall, and the posterior wall is absent. So the posterior wall is absent here. Rectus abdominis lies on the fascia transversale. If you see here, transversalis fascia or the fascia transversale, it lies directly on the, because there is no posterior wall, so it directly lies on the deeper structure, that is the fascia transversalis. The posterior wall of the sheath has free curved border called as the arcuate line. So wherever this posterior wall ends, this is called as the arcuate line. Arcuate, it looks like an arch, so it is called as the arcuate line. Below which the inferior epigastric artery enters the rectus sheath. If you see here, below we can see here the inferior epigastric artery and the vein are entering below. So this is the rectus sheath. In the upper part, we have the external oblique only. There is no, and the posterior wall is formed by the cartilages and the ribs. In the middle part, if you see, both the anterior wall and posterior wall is formed by the rectus sheath, and in the lower part, if you see in the lower part, all the three muscles form, only the anterior part and the posterior wall is deficient. This is how the rectus sheath is formed, which is covering the muscle called as the rectus abdominis. Okay, so here is the rectus sheath covering the rectus abdominis muscle. Now going to the next structure, we have seen the superficial inguinal ring. So if you are, this is the superficial inguinal, this is in case of male. So here you can see the content. In case of male, will be the spermatic cord coming down, and here is the testis here going to the scrotum. So this is the superficial inguinal ring. Okay, now here you can see all the three muscles, the external oblique, internal oblique, and transverse abdominis muscle. Then deep to that, we have the transversalis fascia, then the peritoneum. All that layers have been shown here. Now you can see the structures coming from the abdomen and how they enter into this canal and come as the and form the hernias. So normally, as I said, it will be totally closed except this structure called as the spermatic cord in case of male and round ligament of uterus in case of female. Nothing else is present in this canal. Here is the canal. Okay, so the opening from the abdominal into the wall, this is called as the deep inguinal ring. This is the inguinal canal, and this is the superficial inguinal ring. So now we are seeing the deep inguinal ring. It is an opening in the fascia transversalis, as you can see here. So here is the transversalis fascia, the fascia transversalis. That is the opening. This is the deep inguinal ring. Okay, 1 centimeter above the mid inguinal ligament. So this is the inguinal ligament. So just 1 centimeter above the mid inguinal ligament is the superficial, the deep inguinal ring. Sorry. So, so 1 centimeter above the middle of the inguinal ligament. So here is the middle of the inguinal ligament or the midpoint of the inguinal ligament. So just 1 centimeter above will be the opening, that is the deep inguinal ring, which is opening from the inside. Superficial inguinal ring will be opening outside. The deep inguinal ring will be opening inside. It lies lateral to the inferior epigastric vessels. So here, if you see here, so there will be the inferior epigastric vessels here. If you see, this is the inferior epigastric vessel. It lies lateral, so it will lie lateral to the inferior epigastric vessels. Okay, we'll show in a better picture where it is shown laterally. Okay, so now we can see deep inguinal ring here and the superficial inguinal ring here, and the content. In case of male, it will be the spermatic cord. In case of female, it will be the round ligament of uterus, along with the ilioinguinal as well as some lymphatics. Okay, so here is the deep inguinal ring. This is the superficial inguinal ring, and this is called as the inguinal canal. Inguinal canal. So now coming to the once again all the walls of the inguinal canal. Anterior wall, how it is formed? It is formed by the external oblique. This is the external oblique muscle along the whole length. So this is the external oblique muscle shown in the whole length. It will form the anterior wall, but the internal oblique will only form the anterior wall along the lateral half. Lateral half. So this is the internal oblique, which will form the anterior wall in only in the lateral half. Medial half, it becomes aponeurotic, thin, and it also arches. We'll see how it will arch and form the roof. Okay, so this is the internal oblique. The posterior wall is formed by the fascia transversalis. So here you can see this is the fascia transversalis, where we have the deep inguinal ring along the whole length, as well as the conjoint tendon along the medial part. Later we'll see what is conjoint tendon. So here is the conjoint tendon, which will form the medial wall, and the reflected ligament along the medial 1/4. Reflected ligament along the medial 1/4. So now here you can see this is the superficial inguinal ring. So this is the external oblique muscle which form the anterior wall. Anterior wall, deep inside is the inguinal canal. Okay, anterior wall is from the external oblique along the whole length. Then if you see the internal oblique, so here is the internal oblique. If you remove the external oblique muscle, so this is the external oblique muscle. When once you remove the external oblique, then you can see the internal oblique. So if you see here, it will form only the it forms the anterior wall only in the lateral half. Medial half it is deficient. Why? Because it is the fibers are arching here. If you see here, they are arching and they form the roof of this canal. The roof of the canal. So the external oblique, the internal oblique is not only forming in the anterior wall, but it also forms the roof. But later it will also form the medial wall. We'll see how it forms. Okay. So here you can see here, this is the interoblique muscle forming the anterior wall, the roof, and here is the medial wall. So this is how the interoblique will form around the inguinal canal. Here is the whole of the inguinal canal, and this is the deep inguinal ring. Here is the superficial inguinal ring. This is the deep inguinal ring. You see the deep inguinal ring, it is just lateral to the inferior epigastric artery, inferior epigastric vessel, or inferior epigastric artery, just lateral to that. Okay, so if you want to trace this deep inguinal ring, trace it just lateral to the inferior epigastric artery. So the deep inguinal ring, it is an opening in the transversalis fascia. This is the transversalis fascia. It is an opening in the transversalis fascia, just 1 centimeter above the middle of the inguinal ligament. So this is the inguinal ligament here formed by the external oblique. So just 1 centimeter above the middle inguinal ligament and lateral to the inferior epigastric vessels, just lateral to the inferior epigastric vessel. Okay, so inferior epigastric vessel is here, just lateral to that is the deep inguinal ring. So now again you can see here, this is the anterior wall formed by the external oblique muscle, and here is the superficial inguinal ring. Deep inside we will have the deep inguinal ring. Okay, now see the floor, how the floor is formed. If you see the external oblique, it not only forms the anterior wall, but it winds, go deep inside, and it also forms the floor. So the inguinal ligament, which is the free part of the external oblique muscle, is also forming the the floor. The inguinal ligament is supported medially by the lacunar ligament. So here is the lacunar ligament which will form the floor. Okay, so the inguinal ligament itself form the floor also. The roof is formed, as we saw, is from the arching fibers of the internal oblique muscle, as we saw. So this is the roof formed by the internal oblique muscle, arching fibers of the internal oblique. Now, once again, to revise the boundaries of the inguinal canal, the anterior wall is formed by the external oblique, mainly by the external oblique along the whole length, and in the lateral part by the internal oblique. Then posterior wall is formed by the fascia transversalis along the whole length. Along with that, there will be the conjoint tendon. That is, conjoint tendon is nothing but the fusing of the internal oblique and with that transverse abdominis. That is called as conjoint tendon. Then the reflected ligament along the medial part. Then the floor is formed by the inguinal ligament. The inguinal ligament is nothing but the external oblique free margin of the external oblique is the inguinal ligament, supported medially by the lacunar ligament. Okay, and the roof is formed by the arching fibers of the internal oblique. So anterior wall, posterior wall, floor, as well as the roof. These boundaries are very important because later when you study okay the inguinal hernias, at that time these boundaries are very important, and how to restore the surgery, how to restore, you should know which muscles are injured and how you can restore it. So that's why the anatomy of the inguinal canal is very important. Now coming to the types of inguinal hernia. As I said, the hernias are nothing but the abnormal protrusion of the abdominal contents through the inguinal canal. Okay, as normally I said, it is closed and only the round ligament in case of female and the spermatic cord in case of male will be present in the inguinal canal. If any other abdominal content, abnormal protrusion of the abdominal contents happen, then it is called as the hernias, inguinal hernias. So what are the types of abdominal hernias? Okay, so we are not only talking about the inguinal hernias, we are also talking about the other hernias also. Okay, so the first is the inguinal hernia, which is the most commonest. So that's why you studied the inguinal hernias. There are two types, direct and indirect. Along with that, there are other types of hernia like the femoral hernia, umbilical hernia, epigastric hernia, the hernias through the abdominis, the rectus abdominis muscle, the hernia through the linea semilunaris, and the internal hernias. So these are the different types of hernias which you can see here. Uh, I will take some extra time because we had to have the introduction for this lecture for this block. So I will take extra 15 minutes or so. If we try to finish, if not, we'll continue with the in the next lecture also. Okay. So coming to the abdominal hernias, as you can see here, this is the epigastric hernia, which is in the epigastric region. And if there is any hernia through the umbilicus, this is called as the umbilical hernia. And here is the inguinal hernia. Okay, this is the inguinal hernia. If there is a protrusion of the content through the inguinal canal, and if there is any protrusion of the content through the femoral canal, then it is called as the femoral hernia. Okay, this is the inguinal hernia, and then we have the femoral hernia. Okay, so here you can see here again, this is the epigastric hernia, umbilical hernia, and semilunaris. We saw the lateral to the rectus abdominis, there is a line called as the semilunar linea semilunaris. So if there is any protrusion from there, then it is called as the semilunar hernia. And if there are any incisions in the abdomen, any surgery, previous surgeries are done, if it is not properly repaired, then there can be the incisional hernia through the, if there is any incision and through those hernia, through that, if there is any protrusion of the abdominal canal, that is called as the incisional hernia. Okay, so this is the one of the types of hernias. See here, these are the inguinal hernias. Okay. So, as I said, the abdominal hernias can be of different types: the inguinal, femoral, umbilical, epigastric, incisional, semilunar, lumbar, internal hernias. Internal hernias are hernias within inside the abdomen. Okay. The most commonest will be the inguinal hernias. Okay, and these can be of two types: direct or indirect. Okay, the indirect hernia is the congenital type of hernia, which is seen in case of small children. always congenital, a remnant of the process vaginalis. If it is not fused, then this is present. If it is the patent process vaginalis, then it leads to congenital hernias, and it is most commonest in case of male. Is most commonest in case of males and in children, and usually on the right side, more common on the right side and on the left side. It is common in males on the right side and in children. It enters the inguinal canal through the deep inguinal ring, lateral to the inferior epigastric artery. Then it may descend to the scrotum through the superficial inguinal ring. So it will comes through the deep inguinal ring, passes through the inguinal canal, and comes out through the superficial inguinal ring, goes into the scrotum. So here you can see here. So this is the same. Okay. Superficial inguinal ring and medial to the pubic tubercle. The neck of the sac is narrow. Okay, so this will be the indirect hernias, which is seen in, which is congenital and seen in children, male, and mostly on the right side. Then we have the direct hernia. It is more common in case of old men because of the weakness of the abdominal wall. It is seen in old men than women, and it bulges medial to the inferior epigastric artery, and its neck is wide. We'll see how exactly we can differentiate. So if you see here, any content, instead of passing through, here is the deep inguinal ring, this is the superficial inguinal. Because of the weakness of the abdominal wall, if the neck of the hernia passes through this and directly comes out through the superficial inguinal ring, this is called as a direct hernia. If it doesn't pass through the deep inguinal ring, still here it is, nothing is coming through this, but because of the weakness of the wall, especially in case of old men, so it will come through directly through the superficial inguinal ring. This is called as a direct hernia. Okay, so it is about 15% of the inguinal hernias, common in old men because of the weakness of the abdominal wall, and it is rare in case of women. Okay, hernial sac bulges through the posterior wall of the inguinal canal medial to the inferior epigastric artery. Inferior epigastric artery is here, so it will come through the medial to that. Okay, the neck of the hernial sac is wide here in this case. But the indirect is when the content will pass through the deep inguinal ring, pass through the inguinal canal, comes out to the superficial inguinal ring, then it is called as the indirect hernia, or it is also called as the oblique inguinal hernia. Okay. If it passes through the deep inguinal ring, passes through the canal, and comes out to the superficial inguinal ring. It is more common of the hernias. Okay. So this is the most commonest. So it is usually congenital, almost 20% more common in case of male than the female, and it is almost 30% bilateral, means on either side. If it is present on one side, it is also seen on the other side, almost in 30% of the cases. More common on the right side, more common in children as well as young adults because it is congenital usually, so it is more common in children. Located inside the remains of the process vaginalis, as I see, if you can see here, this is the process vaginalis, this is the process vaginalis. Here it is patent, it is open, so that's why the contents will easily come out. If this is closed, totally closed, then the contents will not come out. Okay, so because it is patent, it is open, so the process vagina is open here, so all the contents are coming through this. Okay, this is the remnants of the process vaginalis. Okay, it extension depends on the state of the obliteration of the process vaginalis. So here it depends, where sometimes it is totally open into the scrotum. Okay, so it depends on the how much it is patent. Enters the inguinal canal lateral to the inferior epigastric artery. If you see here, this is the inferior epigastric artery. If it passes lateral to that, so it has to pass through the deep inguinal ring. So this is called as the indirect. If it passes medial to the inferior epigastric artery, then it is called as the direct inguinal hernia. So this is the difference between the direct and the indirect hernias. The hernial sac lies above and medial to the pubic tubercle. May extend downwards to the scrotum or the labia majors. In case of female, labia majors, and in case of male, it will extend into the scrotum, depending on the opening of the patents of the process vaginas. So these are some of the different incisions which, if you become surgeons, you will take different incision in case of the abdomen. Okay, so one is the midline incisions, which are less vascular, but they are more prone for the incisional hernias, midline incision. So this the A1 is the midline incision. Then paramedian. This is beside para means beside the median. So this is called as the paramedian. Then we have the right subcostal incision. Right subcostal, coastal with the subcostal and this is the subcostal region. This is the right subcostal. Bilateral subcostal, if it extends all the way up to from here to this side, then it is called a bilateral subcostal incision. Then McBurney's incision. So here McBurney's point where we'll take the McBurney's incision, especially in case of the appendicitis. Then transverse abdominal incision. So this is the transverse abdominis, and this is the Fenstell's incision is here, and this is the transverse abdominal. So these are some of the different types of incision which the surgeons take, depending on which is more convenient for them and which is better for the patient. Okay, so this is all about this lecture called as the anti-abdominal wall. If you have any doubts regarding this, you can ask me now. Do you have any doubts?
Thank you, doctor.
Thank you, Dr. All clear.
Okay, thank you very much. So if you have any doubts anytime, you can speak to me and clarify the doubts. So once again, I will repeat. Just go through the student guide. All the details are there. If you have any questions regarding the assessment or anything, we can discuss anytime. Okay. Okay. Thank you very much. Thank you. Thank you for your patience here.